Welcome to another episode of the Patel Perspective. Today we have a postdoc psychedelic researcher, Dr. Devon Effinger. How are you, Devon?
I'm great. Thanks for having me.
This would be awesome because psychedelics is kind of a trending word right now. Mental health is trending word right now. So what are psychedelics?
Yeah, so psychedelics, there's a little bit of debate in the field as to what exactly is considered a psychedelic. People have looped in things like MDMA and ketamine into the definition. But I think the general consensus is that a psychedelic drug would be these sort of serotonergic type classic psychedelics that like LSD or psilocybin. Basically, these drugs that interact with a variety of different serotonin, among other receptors, and produce, visual hallucinations. But beyond that, there's an interest in a potential therapeutic value for these sorts of drugs, as they seem to be able to elicit like a rapid acting and long lasting therapeutic effects after just one or two doses. So there's different classes of psychedelics. I just referenced like these serotonergic psychedelics. There's, mescaline and some other types of psychedelics that are slightly different in structure.
Mm-hmm.
But in general, that would be a definition.
So when we talk about psychedelic compounds, how do they affect the serotonin systems in our brain?
Yeah, so the sort of key receptor that people are really fixated on with drugs like LSD or psilocybin is the serotonin 2A receptor, and it's a what they call like a partial agonist. So it binds to this receptor and promotes activation and excitation of the cells with the and so. But beyond that, it binds to like the serotonin 1 receptor, the serotonin 2B receptor. So there's a variety, and LSD also interacts with several dopaminergic receptors. So I think that while these drugs are sort of in their infancy, there's a lot of focus on the serotonin receptors, but the reality is that we haven't quite isolated which receptor is responsible for the therapeutic effects. So at this point, it's pretty well established that the serotonin 2A receptor seems to mediate the hallucination experience.
Mm. So when you talk about boosting like the serotonergic response, is there like a dysregulation going on between certain neurotransmitters in the brain when we're talking about a dysregulated or dysfunctional brain? Could you give us examples of how potential psychedelic drugs are used right now in research? And then is there like a dysfunction, meaning overall are dopamine levels lower compared to serotonin levels, and that's where we're trying to boost the serotonin system up? How does that work?
Yeah, so that's sort of a misconception. We're kind of emerging out of this idea that, like, for instance, depression is a serotonergic, disorder, and part of that's because the prevailing sort of pharmacological tool we use to treat depression would be a serotonin, SSRI, a selective serotonin reuptake inhibitor, which essentially just increases the amount of serotonin that is available to bind to these. Bind to on the other end of the synapse or whatever. But there's been some work to suggest that this sort of serotonin hypothesis is mostly incorrect. And my way of thinking, there's different levels to like neuroscience research. For instance, there's people who are really into like molecular, synapse type stuff, like what's happening on the cells. There's people that are interested in the receptors. I tend to operate more at like a systems circuit neuroscience level, in that like different brain regions have connections with other brain regions. And when you activate this brain region, it might have connections to another brain region that causes inhibition. And so it ends up being like this sort of complicated circuit, which is just sort of how the brain operates. One of a hypothesis for depression that seems to make the most sense to me is this idea of an excitatory, synapse hypothesis, and that, trauma or early life psychological insults can cause damage to or decreased excitatory transmission within regions like the cortex, which is involved in like inhibition and executive functioning, like the prefrontal cortex, and then the hippocampus, which would be involved in like learning and memory, but among other things. That both of those regions are really also heavily involved in like emotional regulation. And so when you have damaged sort of excitatory glutamatergic transmission in those regions, a consequence of that is that you would have decreased dopamine release in a region called the nucleus accumbens as it relates to reward. And so you can imagine that if that's going on and you have a blunted dopamine response to a rewarding, what would normally be a reward stimulus, that would present as like anhedonia, which is just a general loss in pleasure from aspects of life that would normally bring you pleasure, which is a hallmark symptom of depression. And so the reason why that hypothesis makes the most sense to me is that we have an interesting situation going on. It's sort of an accidental control, wherein we have ketamine and we have psilocybin, which are two drugs with distinct pharmacological profiles in that they have totally different mechanism of action. But at a systems level, they produce similar effects, which is increased glutamatergic activity in the cortical regions. Ketamine operating as what they call an NMDA, which is receptor antagonist, which is just a receptor within. It sort of gets kind of complicated. I won't get too deep into the weeds there. And then psilocybin being a serotonin 2A agonist. And so both through different mechanisms produce excitation in cortical neurons, layer 5 pyramidal neurons, which would then translate to increased dopamine release in the nucleus accumbens. So that's sort of the focus of the work that I'm doing here, establishing that model using preclinical models. And then, as I alluded to, I'm involved on a couple different teams for some clinical trials that are going to be unfolding. And the one focused on treatment-resistant depression will be utilizing some sort of implicit reward tasks to get at some of these questions.
What would be those tasks?
It's like a delayed monetary incentive task. I don't want to get too deep into the details on this trial, but essentially it will. There's very subtle levels of reward, that like somebody who has what I just mentioned would have like it's a reward learning task that's very subtle, and if you're less sensitive to the effect of the reward, you're not going to excel at the task. But it's like so sort of subtle and innate that the person who's taking the task doesn't realize. It's not like a conscious decision that this isn't like rewarding or pleasing to me. They're just their ability to learn this sort of subtle task because of the degree to which the right answers produce reward sensation would be blunted in somebody with depression. And so the hypothesis might be that psilocybin treatment could increase the efficiency and accuracy of that person on this task.
That is so
in conjunction with like fMRI imaging.
That is extremely interesting.
Yeah.
I can't tell you how many times like I've sat down to do schoolwork and like you don't really differentiate if this is depressing or if it's just general lack of interest in whatever you're engaging.
Yeah.
And it's so interesting how these systems work. But I want to go back to trauma. Like how does so when a child goes through trauma, that has to be different than an adult goes through trauma. So when you talk about a child going through trauma, how can we reverse the trauma with psychedelic drugs? Do you think?
Well, so it's interesting that you bring that up because my whole genesis story coming into neuroscience research stems in this interest, almost obsession in this idea that could we potentially reverse the effects of trauma before it sort of festers and manifests and ultimately develops into some neuropsychiatric disorder. What has been shown is that trauma does, traumatic experiences, adverse childhood experiences, at least demonstrated through preclinical type models, show that an end result would be a sort of blunted dopaminergic response to reward, anhedonia. You could have altered excitatory synapse function in cortical regions, deficits in learning and memory, right? So there's a lot of bits of evidence pointing towards this idea that this could be sort of the area in which we should focus for developing treatments for these sorts of things. I mean, trauma seems to be at the root of a lot of different psychiatric disorders, and part of my interest with psychedelics, there's a lot of, like you said, it's a sort of a hot topic. There's a lot of people that are sort of metaphorically drinking the Kool-Aid and just really fixated on these drugs as a potential silver bullet. But to me, why they're interesting, it's a twofold reason. One is that obviously there seems to be a potential therapeutic effects of these drugs, and if it's not psilocybin, it could be some drug derivative that we come up with down the road, whether it's like a selective serotonin 2A, a biased agonist that could potentially weed out the hallucination, like Brian Roth and some people, who was on my committee back at UNC. But there's some work in that field going on. So it could contribute to the development of new, more effective drugs. But beyond that, we're seeing a class of drugs that seems to have potential robust therapeutic effects for a variety of different psychiatric disorders, which to me suggests that there's an underlying mechanism for all of these different psychiatric disorders that potentially researching psychedelics could illuminate for us. We could better understand these disorders in a way that maybe we could come up with some treatment that gets at whatever the underlying root cause is for all these different disorders, and essentially, fast track a solution for multiple disorders all in one.
Interesting. So I'll give you an example of what a scenario could look like, and you can like verify if that could be true in a couple of years. So let's say if I'm a psychiatrist PA, and I know there are rules and regulations on schedules of drugs of prescription as a PA, but that's just for hypothetical purposes. I am able to prescribe a child who has a history of child abuse, like any sort of psychedelic drugs, like ketamine, like you said, or any other classes. Do you think that would be possible? And do you think that's a good idea for kids to have access to those drugs who have been victim of trauma like that?
Yeah, so I think at this point, there's no question that the neurobiological effects of trauma left unattended have huge consequences, right?
Mm-hmm.
I think that some sort of whether it's psilocybin or some sort of derivative, I think it seems to have far less of a intense impact on neurobiology, like the development, sort of persistent effects, than, let's say, like Adderall, or at least it's comparable, right? Like we're giving kids stimulants at young ages, and that for sure would have some sort of prolonged effects on the dopaminergic systems, given that there's such potent drugs for that system. And so, while we see these therapeutic effects, there's also slight concern with the hallucination piece. We have yet to determine if that plays into the therapeutic effects, and so that something like that can, while these psychedelic therapy sessions there's somebody there to sort of assist the process and be supportive to the person or the participant, to the patient that is going through the process. It's largely out of their control, right? Like they're having some sort of internal psychological, in essence, like visual experience, right? Like their eyes are closed, but they're having some sort of like sensory experience. And while there might be somebody to be there to try to help if that person starts to go into like a bad trip, there's not a whole lot they can do. Like you can't really pull the plug on psilocybin. Now, on that note, there's another serotonergic psychedelic which is structurally very similar to psilocin, which is the active metabolite of psilocybin, called DMT, or dimethyltryptamine. It has an incredibly short half-life, and there's actually a recent study exploring the efficacy of basically an IV drip. If you can do an IV drip of a continuous drip of this dimethyltryptamine, produce the same sort of experience that you would get with psilocybin. But as soon as you stop the infusion, it basically takes about 15 minutes for the drug to be metabolized and the experience to be over. But so I could foresee these drugs being applicable in a adolescent population at some point. I think that there's a lot of work that needs to be done to really understand what these drugs are doing, and that's where, like, coming into what I do with like preclinical work, I mean, it's really this a land of opportunity. We skipped a lot of these stages when psychedelics reemerged because there was so much, in the 1950s, prior to the illegalization of LSD and psilocybin, there had been several trials with alcohol use disorder and depression showing potential therapeutic effects. And even though those trials lacked some of the gold standards that we expect in trial, like double-blind, placebo-controlled type of structure for these trials, there was still some sort of a displayed therapeutic effect following the administration of these drugs. And so when we began researching these compounds again in the beginning as early as 1990, early 1990s, and really taking off into the early 2000s, we just jumped right into clinical trials again. And so it's like, that's great, and to some extent, you don't want to delay the onset of being able to offer treatments like this to people that need it. But there's a lot of work that we need to do to really understand and characterize how these drugs work before I think it would end up in an adolescent population. But that said, like, MDMA is about to clear, become a legal therapy. It certainly will be before psilocybin. It's a couple steps ahead of psilocybin on the clinical trial path. And the next step would be to then do some trials in adolescents. And then I would imagine psilocybin probably will follow a similar trajectory.
So do you think these drugs will be prescribed for adult population first, then the adolescent?
Yeah, so currently it's not so much that it's a prescription, right? Like the current framework that's being passed through these clinical trials is a psilocybin or psychedelic assisted therapy, where you're administered a drug during a therapy session, as opposed to being prescribed psilocybin to take on your own. I know that there's companies like Mind Bloom that will basically ship ketamine to people and do these virtual sessions, which, in my opinion, is kind of reckless. But so yeah, it's hard to say. Now, could it potentially be like in the future we have some sort of a microdose type of formulation where that ends up being like a drug that whatever that for instance, if psilocybin, what we do know is that psilocybin and these serotonergic receptors stimulate cortical neurons, then you could imagine that it's a potential application to use these drugs for treating ADD, ADHD, right? Attention deficit disorder, which is also a result of decreased cortical activation. And so now a concern that people have been discussing but hasn't really been, it's an outstanding question. I'm actually designing a study as we speak to address this question, is that I had mentioned that these drugs are also agonists at the serotonin 2B receptor. And drugs in the past that have been shown to be potent agonists of the serotonin 2B receptor were also shown to contribute to the development of drug-induced valvular heart disease, because there's 2B receptors on the heart and it ends up producing a thickening of valve. And so there's, things like these are all questions we need to answer before we start just prescribing these drugs to people. And so when you think about a developing child, there's a lot to consider, right? The brain's going through a massive change, synaptic pruning, synaptogenesis, very moldable. And then it's after 25, 26, when the cortex, sort of finalizes its, major reconstruction, if you're putting drugs into that equation, you're likely causing, shifts that are persistent. And so we just don't really know. There's also a concern with potential genetic predisposition to schizophrenia. And, because a lot of the drugs we use, the antipsychotic drugs that we would use for the treatment of schizophrenia, can also act on some of these receptors that psychedelics seem to be involved in, which isn't that surprising given that schizophrenia is associated with hallucinations.
So, what do we know in your perspective? For instance, I have a lot of knowledge, not a lot of knowledge, but like I have good bit of knowledge about like diets and stuff. But we know that there's not a perfect diet. Like it's all individualized, but there are certain rules in nutrition that say energy balance matters, thermodynamics matters, and then the benefits of protein intake, the benefits of fiber. Like we know there are certain principles, but we're still not there yet with nutritional science. So when we convert that to psychedelic science and psychiatry, what do we really know? Like what we can point out and say, this has to be right. Like the chances of this thing being right are very high.
Yeah, it's a good question. So, I mean, what do we know as far as like what has been replicated? What do the data really show? Some of which I've mentioned. We know that these drugs, the primary receptor that seems to be crucial for the effects of these drugs is the serotonin 2A receptor.
Mm-hmm.
We know, that being said, we know that blocking that receptor will block the subjective effects in humans and potentially preclinical models. Though the way that we measure that is, you can't really ask a rodent if they're hallucinating, but there's different metrics that people have decided are indicative of a hallucinatory or subjective type of dose. So we know that it's an agonist to the serotonin 2A receptor, among other receptors, right? There's been several studies, binding assays, we're looking at how these drugs bind to different receptors. And so we have a good idea of the receptor pharmacology involved with the drugs. We know that the drugs, through various like human imaging studies, we know that these drugs seem to alter connectivity in a way that's, so for instance, some terms that these human imaging studies talk about would be like modularity. And so under normal conditions, the brain has a high degree of modularity in that like certain brain regions make up what they call brain networks, right? And under normal basal conditions, these brain regions communicate with each other a lot, and that's why they become a network. And then there's a little bit of communication between the different networks, between the different brain regions, but it's mostly, there's just a lot of like segregation into these different networks, right? And under the psychedelic experience, there's a breakdown of this modularity and an increase in between network connectivity, right? As opposed to within network, it's now all these regions are talking to each other, or connected, they're functionally connected in a way that they normally aren't. What does that mean? We don't really know. Human imaging is great, but there's also a little bit of like, there can be discrepancies in some of that data because the results can vary based on how the data is analyzed. Different people have different way of analyzing the data. There's obviously like a lot of variability in clinical research because you can't really control for like the diet, right? Like these people are coming in and they're involved in your trial, but they may be eating completely different things. They may have completely different sleep schedules, genetic makeup, right? There's just so many differences in that way. And then beyond that, like human fMRI imaging is measuring what they call BOLD, or blood oxygen levels. And so that relies on the assumption that where there's an increase in BOLD signal, there's also an increase in neuronal firing. And I'm not knocking it. I think, it's obvious that with human work, we only have a certain degree of resolution, right? I can't ethically, put in a fiber optic thing into your brain and measure real time what's happening in certain brain regions, right? Like that's not something anybody would sign up for. So we know that the drugs alter connectivity at this network level, right? It's been shown that that this decrease in modularity is correlated to increases in, or improvements in therapeutic symptom or depression symptoms. and then beyond that, like there's been some, there's very little. I mean, there has been some evidence, but it's ongoing as far as like really deep mechanistic, like preclinical, trying to understand how these drugs are altering specific brain regions. So that's kind of in general, like we have a pretty good understanding of the receptor pharmacology. There's been numerous clinical studies so far demonstrating therapeutic effects, as well as human imaging studies showing altered connectivity. And so I think as this research goes on, we'll gain more knowledge. I mean, the reality is that though there's been a lot of these clinical trials, the reality is ultimately a small sample size, right? Like you think about,
Yeah.
there's been several studies, but it's really not that many people. And I know anecdotally through people that have whatever gone through some of these experiences, let's say just under the radar, some people don't have an effect, right? And my work and the work of some others has demonstrated, at least preclinically, that there are sex-specific effects, meaning like we see effects in males but not females, or females but not males, and depending on the brain region. And so you would imagine, especially when you look at the prevalence of depression, and that there's sex differences in the prevalence of depression and some of these disorders, you would imagine that there's probably potentially differences in the efficacy of these drugs between males and females, biological sex that is. So, but as of yet, that question has not been addressed in clinical clinical psychedelic research. So there's way more that we don't know, which I guess is usually always the case, especially with neuroscience. But it's an ongoing field, and a lot of people are getting involved, and so I'm definitely hopeful that we'll see some gain some insight as this gains more traction.
What are the things online that rubs you really wrong, and the misinformation about psychedelics?
So, I think what tends to happen is that people will. So there's like layers, right? There's like people doing the research. They publish papers because as academics, that's just the metric upon which you're judged. That's it, you have to do that to survive. So these publications come out, and then there's this next layer of sort of journals that will summarize these papers for the lay public, which is great, right? But what happens then is that people see these like trending news articles about psilocybin curing depression or something, right? And then they sort of basically register that as fact. But what the lay person may not understand is that science is an ongoing thing. We've come to several conclusions that later get debunked, or we add to that. Like the answers to these questions is ongoing. Or are ongoing. Its answers are ongoing, and as we get more information, new things unfold. And so it's like, we'll get people saying that that these drugs are the cure for depression, or that it has to do with the TrkB receptor, it has to do with intracellular serotonin 2A, but as opposed to extracellular 2A receptor activation, and that's just based on the findings of one study, And it's like, until something gets replicated, I take it with a grain of salt. That's one study. That's great. Let's see a replication. And that's the whole deal with science. And so I think for me, what I've seen, like there was a huge psychedelic conference that happened in Denver last year, I think, and it had like people like Aaron Rodgers and like, Andrew Huberman, and basically just getting all these famous people to talk about psychedelics. And Huberman I'm not dogging on Huberman, right? Like he's a prestigious neuroscientist. His track record prior to the podcast is great. But what the general public don't realize is that anybody in neuroscience is an expert in a little niche, right? Like you have a basic understanding of neurobiology, and you're an expert in whatever your little niche is. And outside of that, like you have to read and rely on what the people who are experts in those little niches are talking about. And so the problem is that when you get people like, at this conference we had, like I said, the Aaron Rodgers was a keynote speaker. And so what ends up happening is people are like, oh, psychedelics are this positive thing, right? But But what, some things that we don't talk about is that, like, for instance, and I'm not claiming causation here, but Will Smith was doing a lot of ayahuasca prior to him losing his temper where he slapped Chris Rock, right? And it's like, I've also heard anecdotally that after some of those experiences, there can be some emotional volatility. And so the point being that we need to be a little bit more precarious with these drugs. These are very, very potent pharmacological tools that can have devastating psychological consequences, right? It's really, that's the whole setting thing is really important, because it can, the same drug, the same experience can have profoundly therapeutic effects, or it can have potentially profoundly adverse effects. And it's really about, like, where your mind goes during the experience. And so it's not something that should be taken lightly. And again, we don't really know. I mean, there's so many people that I know of personally that are, like, microdosing, and young kids that are microdosing. And I mentioned that serotonin 2B valvular heart disease potential risk. It's like, we may find out in 10 or 20 years that people who are doing this, like, end up getting, there might be massive heart attacks, and we don't really know, and it's just like, I think we should be a little bit more concerned. And I think that, we should also be a little bit more, or just remain objective, like, until the data comes out, as opposed to painting it with this, like, silver bullet, magical, fix all drug. I mean, that's essentially, they're just trying to throw psychedelics at everything and saying it's going to fix it. So, not to sound like a pessimist, but I believe in the drugs. I think they're very valuable for a variety of different reasons. But I remain skeptical and objective, and I think that's the route that we should take.
I think I can add two things to this. The first thing is, like, we as humans are obsessed with solving problems. Like, we love identifying something negative and kind of solving it. Wherever we see things that are wrong, we want to figure out those solutions, because I guess there's a component of empowerment. Like, we want to feel empowered, and we want to be in a certain group of people, even though they're imaginary. And then I think the second thing is that the Dunning-Kruger effect, which you may know. You mentioned that, okay, these neuroscientists out there, they have a generalized knowledge on neurobiology, but then they specialize in things. Huberman, I guess, specializes in ophthalmology, but he probably has generalized understanding on fitness, psilocybin, mental health, but he has an extreme good knowledge in, like, the diseases of the eye, for example. So that's where I think the Dunning-Kruger effect plays, where you, as a person being a psychedelic researcher, you think that there is a lot more, like, maybe there's, like, we are not even 80%, like, we are just only 20% there with psychedelic research. That's what you may believe in. But the people who believe that, or who are the general public, even myself, I have no knowledge on psychedelics, because it's a very trending field right now. And so, going back to my point, is, like, the more you are ingrained in a particular field, the lesser your confidence in having that particular set of knowledge, I guess.
Right.
And so that's very important. This was very important to address in this podcast, actually. It's one of the most important things, because I see this with, have you seen the vegan experiment on Netflix?
Mm.
No, it's like the twin experiments, Stanford. It's like called
Oh,
Stanford.
yeah. I didn't finish it, but I started watching it. I'm definitely going to finish it, because I think that's a great, great design potentially. It's interesting.
It is interesting, but I think the issue with, I don't want to, like, have too many opinions about it, because I'm not a researcher. But the issue with that is, like, when you finish it, it's like, it feels like an ad for veganism, and I can see that coming from for psychedelics on Netflix. Like, they could do the same thing with psychedelics. They could say that psychedelics is all magical, and I feel like the Netflix docuseries about the veganism did really kind of imply that veganism is kind of magical in some way. So I don't want to get too deep into the nutrition of it, because that's what my perspective, like, that's how I'm kind of comparing it, so that people can understand. And maybe obviously if you have any critiques about this, I'm happy that you could share. But that's what I'm trying to like get at, is like, this could happen in Netflix. Millions of people could watch it, and people like you who are specialized in this could be disappointed with the actual docuseries because it lays it out as something magical and everyone should do.
Yeah. Yeah, and I think that's something to be weary of in anything having to do with science is bias, right? You'll see studies, and then sometimes if and the studies may be promoting the effects of some drug, and then when you go and look in that paper at the conflict of interest statement, they're like shareholders in some company that produces the drug that they're doing this research on, right? And and beyond that, like people may have some sort of bias that the people who were producers on that show might be vegans, right? And so they might have crafted it in a way. And so yeah, I think that's definitely a concern as far as when people have too much of a bias and they want to believe in something so much so that they lose the ability to be truly objective in their pursuit of knowledge. That's where we start to see problems, right? And the other thing to consider as well, and this is why I have concern about those third level journals that are just broadcasting the effects of these single papers. And I don't want to get pessimistic, but the academic world, the system is kind of flawed, because the success of somebody as an academic researcher, scientist, professor depends on publishing data in high impact journals.
Exactly.
And in order to do that, you have to have created some sort of provocative story that consists of all these fantastic results. And what that does is when your professional life depends on your ability to produce these provocative, sexy results so that you can get into a high impact journal, that potentiates the possibility for people to be fraudulent, or to basically do whatever they can to make the data match whatever they're trying to get out of their whatever they're trying to show. Mm-hmm. And that's a real phenomenon. There's a real problem with the ability of people to reproduce studies. So it's I don't want to get pessimistic about science, but it's when we begin to have these sort of biases that we all have, it can compromise the data. And so being objective is extremely important. And when we read these studies, for me, if I'm trying to figure out the answer to something, I immediately go into the literature. But I need to see this demonstrated in a few different studies for me to really believe that there's some sort of an effect. At this point, like I said, the serotonin 2A receptor mediates the subjective effects of psychedelics. That has been shown several times. I feel confident enough about that. Whether or not it's essential for the therapeutic effect is yet to be determined, because there's studies where they block the 2A receptor and they block therapeutic effects based on rodent behavior or whatever. And then there's studies where they block it and it has no effect on the antidepressive effects of the drug. And so it's to be determined, right? So, beyond that, the other thing to consider is that with these trials, at this point, expectancy bias is a real thing. It can go both ways as well. If you believe something's going to work, you can harness the placebo effect and get beneficial effects, right? SSRIs and placebo seem to be hand in hand as far as effectiveness. At least it's been shown in trials that placebo at least competes with the therapeutic effects of some of these drugs. But there's also been studies showing where if you believe something doesn't work, you can blunt the effect of the efficacy of that treatment to work, right? And so at this point, anybody who's getting involved in these trials has seen the documentary on Netflix, one of them, right, has probably read Michael Pollan's book, How to Change Your Mind. And so they go into it believing it's going to work, And so that's a real part. And I'm not, at the same time, it's people get obsessed with the placebo effect and trying to parse it apart. And it's, great. If this drug is being, modulating the placebo effect, and that's why we're seeing therapeutic effects, fine. As far as I'm just trying to see, I want to see the effects, translated into a reduction in suffering for people. But yeah, so that's a great point. I didn't finish watching the documentary. I probably would have had a similar feeling as you. I like the idea of, I like controls, right? Like anybody who's a scientist really likes designing an
Yeah.
experiment that has controls such that the more things that you can control for, the more likely that whatever effect you see is based on whatever factor you're altering, right? So in that case, the independent variable would have been the diet, and the dependent variable would have been whatever health outcomes they were measuring. And if everything is controlled for outside of the diet change, then you can feel more confident that your effects are being driven by whatever you changed.
Because that's the problem with human studies. It's just so hard to control. I'm not saying it's really. I'm not saying like you cannot get like good results with human studies, because obviously I'm not a researcher. I'll never be a researcher as of now. But it's just so hard, looks like, to control for
Mm.
everything: sleep, nutrition, the drugs they're taking, interference effects of the drugs, on top of whatever uh, experiment you're doing with the psychedelic. So
You can't, right? You
yeah.
can't, because everyone's had different experiences. And what we know is that the brain is this like constantly changing, adapting, it's recycling different, biological thing, as far as creating new synapses based on whatever brain regions you're activating more, whatever circuits you're activating to do whatever tasks you do on
Hmm.
a daily basis. And especially during those adolescent years, there's no way that you can control for how many adverse, you could ask for how many adverse childhood experiences, but even then it's like there's different flavors of adverse childhood experiences. There's different ways that person perceived what happened and decisions they made based on what happened about themselves, right? So it's like, ultimately, that's why we need preclinical and clinical, right? Preclinical, it's like you have these subjects that are all exactly the same, had the exact same diet, had the exact same life, their exact same age, nothing of the exact same living situation, exact same early life experiences, right? Like, and that's great, but then also it lacks a little bit of there's some translational ability, but also like the brain of a rat is different than the brain of a human. There's a lot of similarities, but there's also a lot of differences, and so that's why like the mix of the two at this point seems to be important. But yeah, outside of like some future world where we can like basically build brains out of tissue, synthetic biological tissue, and somehow maybe down the road be able to construct human central nervous system and do studies in that way. Outside of that, like, all brains are different. We've all had different experiences, and so yeah, I mean that's definitely an issue with clinical research, is that you cannot control for everything. You just can't.
Yeah. Lastly, I just want you to briefly, if you can, I've this. I was just wondering about this. Is our dreaming stage of sleep similar to our psychedelic experience?
So that's an interesting question, that I've and many people have to be interested in. As of yet, there's been no studies to suggest that they're like, so one hypothesis would be that we have at least the building blocks. There's some evidence to suggest that it's possible that DMT, dimethyltryptamine, is an endogenous ligand, right? It's an endogenous chemical, meaning that it
Hmm.
exists inside of our bodies. It's been shown to exist in plants. It's been seen in like rat brains, endogenously. And so obviously, like, we can't like put a probe in somebody's brain and monitor the DMT activity in the dream state, but one hypothesis is that potentially during a dream state, your body would be releasing dimethyltryptamine and producing some sort of a hallucinatory experience. But that's total speculation. There's really no evidence to suggest that that's what's happening. But it's an interesting question outside of what I just mentioned, that we have the building blocks to be able in the brain, the enzymes and the substrates, the different like molecules to be able to produce dimethyltryptamine. But as of yet, like, it hasn't been. There's no hard proof uh, that's actually a real thing. But in some ways, it was like there's a part of me that wants to believe that, like, that thinks that would be sort of an easy explanation for how that's happening in our brain. But yeah,
Hmm.
it's really hard to say that. And people have said the same thing about like near death experiences where people see their life flash before before their eyes.
Certain unexplained uh, things about the mind that just keep me awake while
Yeah,
dreaming.
yeah, exactly.
But
Yep.
I always wonder because I started PA school, and obviously you might know how rigorous any sort of higher level education it could be. And I just finished my second week, and I've been having like these vivid dreams that I didn't have before, and I feel like they're just a response to. I'm not gonna say trauma because like it doesn't make sense, but like just going through challenges and kind of those challenges kind of impacting neuroplasticity in your brain. And that is kind of a compensatory mechanism or like a mechanism in the brain. Like the dreaming is a mechanism in your brain to just, it's kind of I don't know what I'm trying to say, but it's going through a challenging experience in your life results in vivid dreams. You know what you know what I'm trying to explain? I think it feels like that.
Yeah, I hear you. I mean, that
Dreaming.
could be like that's certainly like a Freudian type of belief, as far as like the dreams having some sort of a deeper subconscious mechanism behind them. Um, what's interesting about dreams is that it seems to occur during REM sleep, rapid eye movement sleep, and that's where there's a lot of cortical activity, which is interesting, right? That during REM sleep, you it's essentially when the brain's doing some healing or whatever. Like there's a lot of processes going on. I'm not a sleep expert, so I'm not gonna try and act like I am. But essentially, I know a little bit about sleep, and that seems to be what's happening during REM sleep. So, but yeah, no, it's interesting, and it's something I've been fascinated about as well. Is like potentially the dreams conceal certain things that might be useful for psychoanalysis type of information.
Mm-hmm. Well, these are just speculations, so I was just trying to ask if you have any knowledge about that. But this was an awesome conversation,
Yeah,
especially the fact that how we're not ready for psychedelics yet, because there's a lot to uncover. A lot of confounding variables, a lot of challenges in terms of setting up experiments. But I appreciate you coming on the show and kind of giving our audience like a little sprinkle of what psychedelic drugs are and where are we right now. So
yeah,
thank you so much.
yeah, yeah. Of course. Thanks for having me.
Any last comments you want to make to our audience? Any last things you want to say?
Yeah, I guess want to again sort of reiterate, like, and maybe further explain that I don't necessarily believe that like we shouldn't be doing this research with psychedelics, that we're jumping the gun. I believe in the clinical trials. I'm involved in a couple clinical trials here. I see the potential therapeutic value. What I essentially would hope that the take home here is that there's a lot more that we don't know, and that we should proceed with caution and objectivity, and really like take the time to understand what these drugs are before we just start like everybody takes psilocybin or dose the world kind of situation. Like, I think there's more to learn, but essentially I'm hopeful for the future with these compounds or derivatives thereof in the treatment of trauma-based psychiatric illness.
Well, that's a solid advice for future clinicians, healthcare workers, and most importantly, the general public. So I appreciate you coming on the show, and
Absolutely.
Hopefully we'll have you in the future.
Yeah, no doubt.
Okay. Bye, everyone. Take care.